And so this might be a good opportunity to talk a little bit about viral respiratory illnesses. We're coming into the viral season. Our kids are back in school. They're exposed to a lot of viruses. And so just talking a little bit about virus and lower respiratory tract infections, upper respiratory tract infections, bronchiolitis, all these terms, what does it all mean? Let's talk a little bit more about it. Yeah, fall back too close. You ain't even know me. Trust my word is from way back from the north. Me and the And so when we talk about a viral illness, when we talk about a cold or something, some of the terms that get used are things like a URI, which is an upper respiratory tract infection. And what that would imply is that it's different than a lower respiratory tract infection, right? And so a URI typically involves a virus like rhinovirus, but really any viral process that's really only affecting the nose, maybe the nose and the voice box, but not really having significant clinical impact on the lower respiratory tract. That lower respiratory tract includes our trachea and those small airways. And so really children can get an upper respiratory tract infection from a virus, or they can get a lower respiratory tract infection from a virus. It really depends a little bit on the amount of virus they're exposed to and the nature of what that virus tends to do in the airway. The most common cause of a URI is going to be rhinovirus. Remember, in one of the other posts I said it can be common or normal for a child to get anywhere from 8 to 12 sort of colds in a given year. The typical symptoms are what you would expect, right? Sore throat, nasal congestion, cough, maybe fussiness, maybe low-grade fever. And these are symptoms that are going to last on average for about 8 days, but can last slowly getting better up till about 3 weeks. And as I said, 95% of these infections are due to rhinovirus, 80% of these infections are due to rhinovirus. Really 95% of just respiratory infections in general are due to a viral process. Other viral infections that can be part of this list include things like RSV, influenza, human metapneumovirus, coronavirus, and adenovirus. When we talk about rhinovirus, because it really is, it's so ubiquitous, right? I mean, our kids are exposed to this almost year round, depending on where you live. I think one of the things that is useful to understand is there's over 160 different serotypes or strains of rhinovirus that have been identified, and they will circulate through a community over time, really year round, with the peak season really being around autumn or spring. But because of that, you can get rhinovirus many times. When you get exposed to a specific strain, our body does respond to it. We produce an immune response, but unfortunately that immune response is not protective against another strain. And so you can get rhinovirus multiple times, and we see this very frequently over the course of a viral season. And unfortunately, when we identify it on our typical testing, when we do nasal swabs and do PCR testing, it doesn't tell us what strain, it doesn't tell us what serotype, it just says rhinovirus. Thankfully, at least we think, although some strains of rhinovirus can be very pathologic, it tends to not be as destructive to the airway as we see with some other viral illnesses. And so that's part of why it tends to be more that common cold with those URI type symptoms, although it can be a cause for lower respiratory tract symptoms. One of the most common that we would see clinically will be what we call bronchiolitis. It is a common reason for kids, especially kids that have underlying asthma or that airways reactivity, for them to wheeze. And so if we have rhinovirus and we're wheezing, that's going to be one of our sort of risk factors for having asthma, or at least having those symptoms if we see that we're having wheezing episodes with rhinovirus, because somebody who doesn't have that airways reactivity is probably not going to have wheezing associated with rhinovirus. Now, when we talk about treatment, it really is supportive, right? It's hydration. It's maybe using things like nasal sprays to help hydrate, like nasal saline. Potentially, if the congestion is really bad, using Afrin only transiently for 1 or 2 days if they really are having a hard time sleeping at night because of the nasal obstruction. And then there are some decongestants like pseudoephedrine that can be helpful in a limited manner, but most of it really is going to be supportive care. Most of the over-the-counter things like phenylephrine or even Mucinex and of course the cough suppressants are not very effective, so you're really predominantly just wasting your money. But just staying hydrated, making sure that they're eating well, and general supportive care measures are going to be adequate. When we talk specifically about bronchiolitis, now we really are talking about a viral lower respiratory tract infection, typically in younger kids under the age of 2. RSV is our most common viral reason for bronchiolitis, especially during the RSV season. We're coming into that RSV season that usually is around September, October through March, at least in the area that I live. It can be a little bit different in different regions of the United States. And interestingly, up to 30% of bronchiolitis will be due to up to 2 viruses, sometimes even 3 viruses. So sometimes it's not just RSV, it's RSV plus rhinovirus or plus parainfluenza. But really, RSV is the most common, and bronchiolitis in general as a concept is our most common reason for infants and for toddlers to be admitted to the hospital. Now, I said with rhinovirus, there's 160 different strains. Thankfully, at least currently identified, we have 2 primary strains of RSV, RSV-A and RSV-B. We suspect that RSV-A is a little more common and can be a little bit more symptomatic. But it can really cause a significant amount of problems, right? And it causes most of the problems in our youngest kids, right? So our kids that are less than 6 months of age are at higher risk for being admitted to the hospital. And this is for a variety of reasons. Part of it is related to just their size, their muscle strength, their chest wall kind of orientation, right? So the way their rib cage sits in relation to their abdomen, their cough is just less effective. The types of muscles that they have that help them cough are kind of more fatigue, sort of easier to fatigue, so they have less of that reserve, so they'll tire out a little bit easier. They, of course, have smaller airways, so effectively coughing and clearing that mucus out is going to be harder for them to do as well. But having or being exposed to RSV is ubiquitous, right? Everybody has been exposed to at least one strain of RSV at least once, if not twice, by the age of 3. So it is very, very common. It causes more damage to the airway, right? So as opposed to rhinovirus, RSV tends to cause more damage to the epithelial lining. That's sort of the lining of the breathing tubes of your nose and of the upper airway and into the lower airway. And so along with the body's inflammatory response in terms of mucus and inflammation, there's sort of sloughing of the epithelium, sloughing of the respiratory tract lining into that mucus. And so really most of the symptoms that we'll see with bronchiolitis due to RSV is due to obstruction of airflow from these thick mucus plugs. And so because of this the thick mucus, we'll see that they breathe fast, they breathe heavy, and then sometimes they'll even become gas trapped because they're trying to breathe but air can't get out, or they have a hard time even getting air in. And this work of breathing will be persistent and can really cause them a lot of problems. We'll see often what will be labeled as a wheeze. It's different than a wheeze that we appreciate in asthma because, once again, anytime you make a tube, our airways narrow, in this case it's being narrowed by obstruction from mucus, you're going to generate a noise. There's going to be turbulent airflow. Very often the noise, this wheeze, the sound that we hear with RSV is monophonic because this infection is affecting our lung more uniformly than in an older child who maybe is having an episode of asthma. But also we'll see them breathe sometimes very, very fast, up to 60, 70 breaths per minute. We'll see that increased work of breathing, the retractions, because they're trying to breathe through all this thick mucus. You'll see sometimes there'll be episodes of apnea in our very young infants that are 2 months of age, at least 2 months of age or under. Though just having RSV itself can be a reason for what we call primary apnea, where they just stop breathing, which can be pretty scary. And so this picture down below, or this graph, I think really sums up a lot of the components in one picture that we see with RSV bronchiolitis. So you can see that, sort of rapid onset of symptoms with really our peak symptoms being there around day 4, day 5, with that variable really up, down in terms of their oxygen levels, their work of breathing, their cough, their mucus. I mean, they're just up and down, very, very sick, and then look a little better, and then they look sick, kind of sort of teeter-tottering, if you will, over those few days, and then they start this process of slowly getting better, really sometimes for up to 3 weeks of this gradual improvement. I think you can see on that picture, though, you can see what would be a normal bronchial lumen, right? Unobstructed, airway, and then to the right of that, you can see that the obstructed airway that's just full of all the cellular debris, the epithelial cells, all the mucus, and you can see why it would be very hard to breathe through that. As I said before, really our kids that are at highest risk for hospitalization are going to be our young infants that are under 6 months of age. Certainly if it's any of our young infants that are also on the smaller side, so if they have a low birth weight, if they have any underlying airway anomaly like tracheomalacia, bronchomalacia, if their airways can collapse, if they have any problem with their immune system, any immune disorder, if there's parental exposure to smoking, that can make the inflammatory response worse. If they have underlying chronic lung disease, so if they're born premature, or if they have underlying congenital heart disease, that's going to put them at increased risk. And then if there's any other kind of diagnoses like neuromuscular weakness, cystic fibrosis, Down syndrome, these are all factors that are going to make their kind of clinical course with RSV and with bronchiolitis more significant. Now, I think one of the things that's been observed over time is an association between early RSV illness and then ongoing symptoms. And this has been studied and has been a little bit more of a complicated issue. It seems to break down into a couple of different sort of blocks of kids, right? There seems to be a block of kids that will get RSV often early in life, or at least will be symptomatic, very symptomatic. And there was actually a really great study out of Arizona, Tucson, Arizona, where they looked at a block of kids and they did infant pulmonary function testing really before they were ever sick, really essentially early in life. And then they followed those kids over time. And they found that the kids that were more likely to have wheezing and difficulty with RSV had decreased lung function, or at least decreased airflows even before that. And so there's this concept that some of these kids that have problems with RSV and go on to have recurrent problems, it's a structural piece. It's an anatomical reason or explanation. It's the way that they were born in terms of airway size, diameter, and function. And those kids outgrow it as they get older, as they grow. But that's not always the case, and there does seem to be another subset of kids, especially if they get RSV early in life, if it's a significant viral illness that lands them in the hospital, that there may be some impact on either the way that nerves control the airway, sort of the kind of neuro or neuroimmune mediated control of the airway that puts them at increased risk for twitchy airways, kind of airways reactivity with subsequent viral illnesses. In general, we think that those kids also seem to outgrow it, so it's not a lifelong problem. But then there's also a concern that early RSV infection can cause epithelial damage, right? We talked about the sloughing of the cells, but just causing primary damage to that barrier, right? The respiratory epithelium in the nose and in the airway is really there to protect our body from the outside world, right? Our airways are the largest internal organ exposed to the outside world. And so if there's breaks in that barrier, it might facilitate exposure to pollen and to allergen or to other things that are going to change the way our immune system develops and might skew it or facilitate a more allergic type framework that could put us at increased risk for asthma as well. So there is some concern that may be part of it as well. So these kids, for different reasons, may go on to have recurrent wheezing and coughing with viral illness, and depending on why that was, it might dictate if this is short term or whether it's long term. Yeah, fall back too close, you ain't even know me. Trust my word is wrong, way back from the north. Me and the